Then whenever Luke's ready, we will.
Go ahead and say and spell your name for me.
Suresh Lohano, Suresh Lohano, Lohano.
Okay. Good.
Yep, you're good to go.
All right. So tell me the whole about this new rounding procedure. What does that look like?
Yeah, so we were doing some sort of multidisciplinary rounds before this, which a lot of hospitals do it. I've been president for Society of Hospital Medicine Indiana chapter, and have been involved with hospitalist medicine for 19 or 20 years. Okay, so and I'm actually on the national level, but this and I've done they call geographic rounding, they call it multidisciplinary, interdisciplinary. There are different names, but usually that involves when you are after rounding, you meet with some of your key people and then talk about patient. Okay, that's different. What we thought about 6-8 months ago, and I got an opportunity because I could change the process because I had a change in my staffing, and we made this acute care unit, which is nice and beautiful now, and really we're blessed to have this because renovation made us that we have now ICU on the same floor, and we have medical surgical unit on the same floor, so we have all the beds, everything about medical and surgical on this floor. So what I think that gave an idea is, why don't we just do rounding in the patient's room and bring every key player and every key member of the care management team in the room with us. Okay, so that's really what we, and I think that was a good idea. Of course, it also comes with a passion that you want to improve something, and see, when patients walk out, they have a perception that nobody's talking to each other. That's really the common complaint you see. And my doctor didn't talk to my nurse, and nurse doesn't know what's going on. Doctor didn't tell her or tell him, and then my case manager saying something else. I need to go physical therapy and nursing home, but my doctor said no. So it's kind of like all these miscommunications, because people perception is different. When you talk, you give them options, and they don't get it. They're sick people at that time because they are going through the acute illness. So I think my idea was to bring everybody in the room. So what we do is, myself, and I start rounding at 9 a.m. and or sometimes 8:30 or 9, and then we I take my cart. I have a laptop with me, which I've been doing that laptop for a long time. I take the laptop, I open the patient chart. So now we have a whole patient chart in front of the patient, and we have patient, and if there's a family member, great. If not, we dial the phone line and just ask them who they want to connect, if they want to connect. Then we have my nurse. Of course, she's a key component because she's there 12 hours of the day. So that's just, she has most valuable information about the patient because she has a report from the last shift, and she has a report from CNAs and everybody else, or any other physician might have rounded. So that key player is there. Then we have our case manager, which is a key component in terms of planning for in the hospital any resources they need, and then they need any resources after the hospital, which is really a challenge in this insurance world, isn't it? Whether they want to go to a rehab, or they want to go to the physical therapy outpatient, or they need a home health, or they need unfortunately sometimes hospice, or whatever they need. I think the case manager is listening to this lively conversation with the patient and then understanding why they need what they need. That is the important thing. This is how they can convey the message to the next level, because otherwise they are just getting an order from me after the fact. So that, and then imagine the value of pharmacists being there. How many times you see a pharmacist in the patient room, in the offices, or even in academic institutions? I've been there before, and you don't see pharmacists in the room. So we brought a pharmacist. She's very interested, very passionate about inpatient acute medicine, and she's actually excited to be on the team. So I spoke to her, and she said, "Yeah, great. This is a great idea. I want to do it." And I spoke to their department head, and so we brought her on, and I think that has added a lot of value to us, because sometimes we go through, actually most of the time, we go through all these medicine lists with the patient, and we find sometimes duplications, which sometimes I don't get it. And there's a lot of new medicines out there, which sometimes you just don't realize they may be interacting, or there's some reaction, or drug interaction, or contraindication. So all these things. So she brings those up. Of course, we are in the hospital, patients are sick, we're giving them sometimes high-powered antibiotics, we're giving some of the medicines which are not the routine medicines. So when they're on routine medicines, let's say we're giving them daptomycin and they're on a statin, well, you can't combine those. Now, a physician has to know that, but if they don't, at least pharmacists know that. So you have this safety net. So we have 2 people now looking at your medicine who are kind of qualified to do so. So I think pharmacist value is huge. That is cannot be more emphasized. So we have case manager, we have a nurse, we have a pharmacist, then we have a dietitian. Now imagine, diet is a toxin also, and diet is also a therapeutic, isn't it? So you can go in either way. So we have dietitian who around with us. She actually, so somebody, we have patients who are diabetics, who are malnourished, who have, of course, obesity, which is common. So of course, she doesn't talk about all those things in the room at that time, but she get to see this lively version of what's going on with the patient. Why patient is sick? What are the risk factors? What are the diet implications here? They are here with diverticulitis. Maybe they need something different. They are here with high blood pressure. They need maybe DASH diet. They are diabetics, so they need maybe ADA so and so diet. And everybody is different.
The stethoscope just hit that pretty bad. You can keep that on. Let me do something real quick. I didn't mean to cut you off.
No, you're fine.
Just gonna get this to the inside collar.
I would rather you catch it now, Luke, than
Yeah, I just wanted to make. It all of a sudden hit, so
you were getting too passionate.
I am passionate about it, so I can talk about it for hours because this is my project,
Well, that's what we're here for.
Yeah.
That's the reason that we're here, but we want to
Okay.
make sure this sounds
Well,
good.
stop me if I need to stop somewhere.
No.
No, okay.
But we're going to restart with the dietitian.
Okay.
Just so you can mentally prepare for that.
does that look okay?
No.
No.
It will
Switch
if
that
we...
this way. There we go.
Julie's going to move that cord. Okay, there we go. Okay.
Okay.
Ready?
Yes.
Okay, so the dietitian.
Yeah, so the dietitian is a huge player here because it's a diet can be toxin, diet can be therapeutic, and patients have different health conditions. They are coming with diabetes, hypertension, so we have different kinds of diets, and patients don't know that. And actually, even they don't know that, they cannot implement because they need some sort of guidance, and they need some sort of, because everybody is different. They have different lifestyle. Not everybody works 8 to 5. Some people have evening shifts. Some people they're on the road, like they're working like people who are traveling to Evansville or Indy or somewhere. So everybody need to be customized for their diet plan, and that doesn't happen, of course, in the room at that time. But for dietitian to know the information at that time lively, she's listening to it, she's seeing what problems patient is having, and what socioeconomic factors play into that. So I think that that first-hand knowledge what she get, and of course she gives some tips, but then she goes after the round again and makes sure she emphasizes a few things, and then we make an appointment for them to see if they are interested. I think that's a huge thing in America. We have lack of dietitians involved in the acute care medicine. We have dietitians for diabetes outside in the outpatient world, but I think the acute care is a place where you can catch a lot of these things. And so I think that actually I just texted her to come and talk more about it if she can, but I think that is a huge factor, plays into patients' health, in my opinion, because it's just unhealthy diet, and that is non-compliance or not knowing, and there's information out there, but I think it's just not in the format where they can is palatable. And of course, then we have a very, very key component, Larry Schartz. We have an MIH program. It's a program which is a grant funded by Indiana State, and insurances don't pay for it, but that's fine. What we did is, almost a year ago, we started this program, and we want to provide this post-acute care continuity. He's excellent. He's paramedic by training. He's very passionate. Again, all these people on the team are passionate about it. They didn't come because we just forced them to do it. And he will talk about it, but so he's listening to all this. So when we admit the patient is here for 3 days. He's rounding with me. Running with us and listening to all this information, and we introduce to the patient and family, and then offer them. Of course, they have a choice. They don't have to, but if they sign up for this program, then Larry makes a call to them, make an appointment, like go to their house, family present or what, and then he assess the situation at home, and he also goes over the medications again, make sure patient got it. So sometimes we perceive that we gave them instructions. We wrote them all these nice, antibiotics on a piece of paper, or we wrote them prescription. Did they even pick it up? Maybe they couldn't afford it. Maybe I wrote a prescription which was $400, and they say, I don't think I need it, So I think Larry picked those small things, which prevents them from getting worse. If we can, then he will call us, or he'll call the PCP, primary care doctor, and say, hey, this patient was in the hospital, went home, got this prescription or this happened and he cannot take it, or he's taking it, he's having side effects. Sometimes they were getting hard to get hold of physicians. So Larry kind of bridged that gap. So I think that role is not as much used in America as it should be. We have a gap in the care. We have acute care hospitalist programs. So when you go to hospital, you see a hospital, you see all these physicians in the hospital, and most of them you don't see in the outside world. Then you go and see your primary care provider, nurse practitioner, PA, and they have gap in knowledge. Their skill set is different a little bit than what skill set we bring here. But beside that, the gap in communication from the EMRs and from so the patient feel like I'm lost. I don't know, Dr. Lohan said this and he's saying or she's saying this. So I think that Larry goes in and I think try to complete that bridge, and he actually make calls to the primary care. He makes sure the patient's discharge summary from us went to the PCP. He makes sure the patient got the medicines. Or sometimes there was a patient he saw actually couldn't afford the meals, so he actually found vouchers for them to get so he can have the meals. I think these small things makes big difference in patient health. So I think that is again big piece for us as a team. So we have really good these members. What we're taking to the next level is, which is what we'll be working on this summer, is giving them instructions in the video format. So this is something new and hasn't happened. This is a project I did in my MBA 2015, and I kind of won the award for that, but couldn't bring it to the life. So I think this is the time now. I have these all people together, and what we want to do is the next step. When patient is going home, we want to create a set of instructions in a video format with more kind of funny a little bit, more entertaining, but at the same time more to the point. Now think about when you get home. I don't know if you've ever been in the hospital, and my wife has been in the hospital, and we get this packet of instructions. Nobody reads it. It goes to the junk, isn't it? Or they get sometimes the instructions you can't understand. We want to create 2-minute video clips in a really nice animated way, and those videos we want to send to the patient in a secure format, and we want to emphasize on really the key things in those 2 minutes, because people don't have much attention span. And those videos can be shared by patient to their family. So let's say a patient here and her son lives in Indy, or her son lives in anywhere, or they want to know what doctor said to them, or patient forget, because a lot of these patients we see in their ages, they're sick, they want to get home, their last thing is to want to remember their instructions, so they forget all these. 90% instruction people forget, by the way. So if you can give them in a format which they can just put it on their smartphone and play it and watch it for 2 minutes, I think may actually improve their information about their own health and what they need to do. Don't have to be a lecture about diabetes or hypertension. It's just be simple, like this is what I need to do for my Lantus or my insulin or my medicines, or need to go to pharmacy, or need to see my doctor, or need to go for my wound care. Things like that. So yeah, I think that's where we're trying to improve, is bringing everybody in the room, improving the transition of care, improving the care in the hospital, and then improving the instructions for the patient.
So we've established that you and your team have a lot of passion in this, and that has driven a lot of this, and it's caused the success. But can you talk to me about some of your patient interactions, or the good stories, or the things that you've caught or that Larry's caught that continue driving that passion?
Yeah. So, of course, passion is, I did this project, by the way, in 2016 at another hospital, and I was a medical director, and it failed. And honestly, it failed because it's not because I did not have money or resources from the hospital, it is because the people on the team were not passionate. So I'm a big believer in, if you're not passionate about it, don't do it. It's just and this has been my passion for a long time. I tell people, medicine is my religion, not my profession. It's just because that's how you practice. So I think that is an important part of anything you do, and especially things like this where it's not going to be any more, because sometimes the incentive comes from making more money, isn't it? This one doesn't bring me any more or anybody else more. It's just about doing it because you like it. Some people do more because it's an incentive, I'm going to make more and things. That's really not what the idea was. It's just, I think we can do it. We have capability to do it. We have, and then somehow we just all together met. I think it's just came all together, and I'm actually very proud of it. And hospital support, its leadership is a big supportive. They have given all the resources, so I think that is a great thing. The stories, as simple as it is, we go and, as I said, Larry, we had a patient who was having low sugars, okay, and was on insulin and was on some other medicine, on glipizide and things like this. And I went over his medicines, okay, this patient medicine, and I explained, like, hey, these medicines are not supposed to be on because this is what causing problems, and this is why you're falling or passing out or feeling weak and all those things. And his sugar, his A1C, which is a diabetic marker, was low. So we explained him, and we gave instructions. Goes home. Somehow he got old instructions again. So whatever we did here actually didn't, went very well at home. Larry goes in, look at that, and hey, Dr. Luana said you're not supposed to be on, and you're on these medicines. I said, well, I didn't realize that. So he had an old set of instructions, looks like. God knows what happened. But anyway, I think that piece, he called me, he told us, and said, okay, well, it's just, we need to get this off. So that helped him. It was a small, simple thing, simple fix. But again, if you think about it, if he keeps doing the same thing, back again in the hospital, maybe a worse shape or form, maybe pass out, maybe comatose, and maybe kidney injury or whatever because of low sugar, and then maybe another hospitalization, maybe cost to the, well, not maybe, most likely cost to the insurance companies or somebody, and sufferings for the family and patient. So I think that all can be avoided by just simple communication, simple step where, of course, patients have to, take the lead on those also. I kind of, this is another thing I think we need to educate is, I tell my patient, I'm your GPS, you are the driver. I can't drive for you. And so I can tell you instructions, and very clearly, like how you go in put in a Google and they'll tell you all right, left. But if you don't follow, you won't be at the destination. It's not going to happen unless you by mistake make it. But so I tell them all, my role in healthcare as a physician is your GPS. I'm not going to force you, but I'm going to give you all the information and resources. I'll do what I can with the limitations I have. I mean, of course, I don't have one patient, but then it's on you at the end that and that patient factor has to come and play also. But I'm sure people want to do that. It's just about talking about it. So yeah, that's.
Is there anything else that you would like to tell people about this practice?
I think the people, when they are in hospital medicine, and of course I have, I enjoyed this 20 years in hospital medicine, and I still love it and enjoy it. And actually, maybe, gotten better at handling things. What I tell people come with expectations. And we try to meet expectations, okay? But, sometimes expectations can be unreal too, okay? When people come and, if they want, Ritz-Carlton and they go to holiday, and it's not going to happen. I'm just saying is, this is a community hospital. We have limitations. We have, resources which we have for small hospital. And we do, I think, best and better than a lot of hospitals. We ran a COVID floor here, and I was actually praised by bigger hospitals how we are running this. Same format kind of we did at that time. We had a 1.5 year COVID, full ICUs. We had, we everybody went through COVID, and we actually got a lot of letters from St. Vincent Deaconess how we were running the floor at that time. And I think people need to sometimes just realize, we of course cannot do everything, but this is a great hospital. This is a community hospital. I would like them to support it and give us a chance. Test it, make your own, opinions, but come with a, mindset which is realistic, And I think the other reason to support is because you'll see in America, and rural hospitals are closing because, you can't keep those open, and a number of reasons, of course, insurances, payments, expenses have gone up since COVID. Everything is just, expensive, and we know that, people go for groceries. It's not, hidden, isn't it? Same applies to hospitals. Every cost has doubled or tripled since, we went through COVID. But our reimbursements are same. If I was getting $100, 5 years ago, I'm getting $100 today. For that $100 today is like $50 to me now. isn't it? Same thing for you. So I think the people need to, we can't have everything sometimes. So so we try to run as efficient as we can, and so that need to be understood by American healthcare consumer. It's just not easy to function in a hospital, in a healthcare setting, and have everything and then expect everything. So I think that's a general statement. I'm not talking about any Washington. I think in America, people need to realize if you start spending, if you look at the healthcare expenditure, if we keep spending money the way we are spending, I don't think we'll have a lot of healthcare remaining. So I think that is a key to understand. Use the resources wisely and be careful. It seems like it's your own thing, just so that's what we try to do. But yeah, I think I've been here 20 years, great hospital. This is my home. I tell people I might, retire here and die here, who knows? But I would love to take this word out and trust us, give us a chance, and we'll make it, we'll make it work.
Terrific.
Yeah, you are just a
The hardest part of it is this. Can I get you to say and spell your first and last name for me?
Say and spell my first and last name.
Yep.
My first name is Linda, Linda, and my last name is Myers, Myers.
That's why I do it. Go
Mic
ahead and
check.
spell your first name for me. Just I do that for a mic check, and there was something wrong, so I'm gonna make sure it's right now.
Okay. My first name is Linda,
Very good.
Linda,
Okay.
perfect.
and I'm gonna need more water.
Can I get you more?
No, I got more. I just need to get it right here.
I'm gonna make sure that you. We've got plenty of people in here. Somebody can run and get you some.
Good. Let me. Yeah,
Ready?
I'm good.
Okay, so you have a very unique perspective. We're talking about the new way of rounding on patients and having your full care team in the room with you at one time so everyone's communicating.
Yes.
How does that feel to have that kind of support from your perspective?
Well, at first it was a little startling to have so many people gathered talking about your plan of care, but actually it feels good because it feels like you've become a real person to that team and you're not just a name in the computer. So I think that's good. I think it makes for more open communication, and you know somebody's face, so it's easier to ask a question.
And do you feel like overall your care level has improved due to this?
I think it's been really good. Actually, this is the first time I've been hospitalized since my son was born, so I don't have a lot to compare it to. My husband was hospitalized multiple times prior to his death, and it's certainly the level of care certainly seems improved now because you can actually see people communicating with one another, and you know that they're. I've just really felt like, right from the beginning when I got to the ER, it was a team taking care of me. So it was kind of like, instantly when I walked in the ER. So I feel good about that. I think it's a good thing.
I'm so sorry for your loss, but thank you for sharing that with us.
Yes.
Is there anything that you would like to add or anything that you would like people to know to comfort them about, there is a large group of people that are coming into your room, but is there anything that you would say to set their mind at ease about that?
Just what I've said already. I think it opens up communication, and you just know people. you know people, and I've experienced, like, you know, every day there's a parade of people coming in here testing, and are you all right? Do you need anything? So you get a feeling that even though the door's closed, there are people on the other side of it who care about you and who want you to have their very best care. So.
Thank you so much. You're natural.
For me.
John, John, Gear, Gere.
Good to go. All right, so tell me from your perspective as the family how it feels to have this new rounding technique.
It was very comforting to see a team of people come in here and communicate amongst themselves and with my mom and myself. It was a lot more, it just seemed efficient that way, and it was very personalized, and everybody knew what was going on, and it was just a relief when you're sitting where I'm at, having concerns and wondering what's going to happen, to be able to get the information you need and then to get questions answered. It was very comforting to know that that was how they were handling it.
And I know that they also make an effort to dial in or call in if someone isn't in the room and present. Have you ever experienced that?
I've been here a lot of the times, but I always, even when I'd come at different times, I never felt like I didn't know what was going on, or that I couldn't find out quickly if I needed to. So the communication level throughout this has been outstanding.
Wonderful. And what would you say to someone that maybe is helping make decisions for a family member or for themselves to put their mind at ease and to encourage them even to come to Davies Community Hospital?
Sure. I mean, I think what Dr. Lahano is doing with him and his team and the way they're doing things is a huge asset to our community. And it's something that, you know, people, I mean, obviously when you have to make decisions for a loved one, it's not always easy. But the way they go about it, the communication process, the compassion that they show you, and how they are open and willing to sit and answer questions really should ease their mind when they come here. And it's definitely an asset to the small community to have that opportunity to get this kind of care here in Washington.
Is there anything else that you'd like to add?
Overall, it's just, I mean, obviously it was not ideal to be in this situation, but they've done everything that they could to make it as smooth as possible and to ease concerns and just to make this, you know, very comfortable for everybody involved.
Wonderful. You are both my...
Spell your first and last name for me.
Jacelyn Schweitzer, Jacelyn Switzer.
And one more time for me, just to make sure.
Jacelyn Schweitzer, Jacelyn.
We're good.
Okay.
Okay, perfect. All right, so the hardest part of this is that you're going to look at me and ignore the camera.
Oh, okay.
So Dr. Lahano gave a big compliment to you earlier and said that you were probably the most integral part of the team because you're with the patient the most. So can you tell us from your perspective what this new rounding technique means and provides to the patients?
Yeah, this is the third hospital I've worked at, and no hospital that I've worked at before has had something like this. And so when I first came, I was like, oh, this is different, but I find it very beneficial, not only for the patient, they get to be involved in their care, they get their questions answered, families present most of the time, they get their questions answered, but it's also very beneficial for the nurse. If I have a concern, I can bring it up in front of the patient with the patient. It gets addressed right then and there, and it's nice to have everyone included. Medication questions, I have the pharmacist right there. If I don't know where the patient's going, if they're not going home, I have case management right there. It's just very helpful to get my job done versus sitting on a phone all day, calling everyone, trying to figure out what's going on. So it's definitely very helpful.
Do you think that this technique provides you more time with the patient, considering that you don't have to be on the phone and chasing everyone down?
Yes, it definitely allows for more time, yes.
And then is there any stories that you can share, like success stories where you were present and something was caught, or you were able to point something out that maybe would have been missed had everyone not been in the room together?
I don't really have a specific story, but a lot of times we have elderly patients who are confused, and it's very important to have family there because they can't always tell you exactly what their history is or what medications they take, and sometimes family can't be here, but Dr. Lojano is very good about calling them and then putting them on speakerphone, so it's like they're in the room, they're still involved in the conversation, and that has been really helpful. It's helped us get a better idea of what's actually going on with the patient when they're not able to tell us completely what's going on.
What kind of feedback have you gotten from the families?
I think the families really enjoy it. Like if they're here for a couple days, they'll realize what time it is in the morning, and they're like, oh, is Dr. Lojano coming yet? Is he here yet? And so I think they look forward to it because then they're in the loop, and it's not a phone call from the nurse saying, hey, this is what's going on, but they get to actually hear it firsthand from the doctor.
Is there anything that you would like to add or that you would like people to know?
I tried to think of things that I wanted to say,
You're
and now
okay.
I can't remember.
You're okay. So you're the one in the room, 12 hours a day. You're the one that has the information from the past 12 hours. So can you tell us just a little bit about what it is that you bring into the, aside from, medication questions, but what that unique perspective is like whenever you enter the room?
It's definitely helpful because night shift isn't here at the same time as Dr. Lojano. He may get phone calls from them in the middle of the night, but he doesn't necessarily get to hear the whole story of what they experienced overnight with the patient. And so it's helpful. Like I had an instance today where I brought up a concern that the night nurse had that was partially addressed overnight, but not completely. And so now we're going to run another test today to address that problem. And so it's helpful to kind of pass along what happened the last kind of 24 hours, not only just what's happening on my shift.
Wonderful. Anything you think of? You're great.
Okay.
Your first and last name for me.
Larry Schatz, LarryShots.
Okay.
Okay, so the hardest part, you're going to look at me the whole time.
Okay.
Okay, so you are kind of that in-between care of I'm in the hospital and then my primary care provider. Is that true?
Yes. So the way this program works is as a team here at the hospital, I do roundings with the physician here at the hospital. So I get to see the care that's going on with the patient, and then the transition to home, I get to follow the patient home. And the team care continues with that because I still have resources from the hospital that we can pull from. So if they need to go to wound care, if they need physical therapy, we can send them to our core center. We have a cardiac pulmonary rehab that we can refer them to. If they have substance abuse, we can refer into peer recovery. Or if they have anxiety, depression, we have transitions that we can pull into. But what I do is I transition from the hospitalist here at the hospital, and then I start working with that family physician that they normally see at home. So they can have multiple specialists that they see, but it's that primary care physician is who I work with. And I'm their eyes and ears at the home for that patient. So a lot of times the patient may take other medicines that the primary care physician doesn't see, and that's one of the biggest things that we run across is make sure that that primary care physician knows what medications that patient is taking, and then working with that patient on how to take those medications. So that's one of the biggest items that we run into, especially if they have multiple doctors. And then we help them navigate the healthcare system. So with the MIH program, if they see multiple doctors and need additional procedures done, then we can help them navigate that. We help educate them so they can do this on their own, but we're that extra support. As they go through all this process at home, I follow up with them doing medical assessments and reporting that back to their physician. If there's something they need at home, resources so they can heal healthy at home, we work on the social determinants of health. So if they need wheelchair ramps, if they need Meals on Wheels, if they need transportation to make sure they're safe at home, that's part of the MIH program is to work on those social determinants of health. So we're the eyes and ears of the doctor to make sure that patient is healed and healthy. And this program, so this team concept going from the hospital to the home has been an excellent program. We've seen positive results to where the patient is, they're nutrition is better, so they're eating it and they develop a healthy living habit. I've seen a decrease in obesity with it, decrease in medications that they've had to take. Example would be some diabetics have actually been removed off insulin because they've changed their diet and able to keep diet control for their diabetes. We've worked with people on quitting their smoking. And then those with substance abuse, we've worked with our peer recovery, shadowing in with me, and able to get people into recovery.
So can you elaborate just a little bit for me on how much easier it is for you in your job by being in the room with the whole care team?
So being part of the care team in there, I get to know exactly what's going on. So this way, it's nothing to where a patient is discharged from the hospital and I have no clue what's going on. I'm with them in the care that they're receiving here at the hospital. So I take that information and it's easier to follow them at home.
Is there anything that you would like to add to maybe put people's minds at ease or just encourage them to stay local at Davis Community Hospital?
So having this closed network to where we can use all the different resources, it makes it great because even though we're a small hospital, we communicate well with each other. Everybody within, we're like a big family, and we're a family and a big team to help you get healthy at home. One of the, something I want to add to it, one of the deals that's different between the MIH program and home health care is I have policies and protocols to where I can treat the individual there at home. But before I do that, I reach out to the primary care physician and we work with the medications. So I've had patients with heart failure that have increased with the water retention. Working with the primary care physician, we've increased their dosage of their diuretics, get that weight off and get them to a certain goal. With diabetics that are high elevation with their blood sugar, working with them on a sliding scale to get their sugar down to a certain goal. We do that slowly. And like I said, that's all done through working with their primary care physician. Working with the individuals that have COPD, they have respiratory problems. They have that medicine already there. I educate them and show them how to take care of themselves so they don't get in that emergency situation where they have to come back in to the emergency room. So a lot of this is educating the individual at home how to take care of themselves and work with their PCP to take care of themselves.
Wonderful. All right.
Okay?
Please say and spell your first and last name for me.
Yeah, it is Annie Williams, Annie, and Williams.
Okay.
Good. Okay, so the hardest part is you're going to look at me the whole time.
Okay.
So explain your role on the care team.
Okay. I just travel with the care team in the patient rooms, and while I'm in there, I review medications from home and make sure that we have the medications on accurate list, which is difficult across the country for any hospital to do. So it's really nice to do that while we're talking with the patient upon admission. I will monitor, drug-drug interactions, make sure that we have appropriate therapy in place. Some things that are commonly missed without care teams would be like ulcer prophylaxis, DVT prophylaxis, things like that. So it's nice having an extra set of eyes on hands for things like that. We try, when the patient's going home, to make sure that we talk about, side effects, how you're supposed to take the new medications at home, any medications that you're going to stop, and really explain why we're changing things during the process. So try to get a little bit more explanation as we're going.
Prior to,
I just need to flip over that mic.
Oh, my hair hitting it?
Yeah.
Can-
I got you.
Yeah.
I think it was your necklace, maybe.
Oh, gotcha. Sorry.
we're going to pull that down.
There
Okay.
we go.
Perfect.
Do you need her to just say that again?
I don't think so.
Okay.
Okay.
Okay, good deal. I was like,
I don't know if I could do that again.
well, you could. It would just be a version of. So prior to this new technique or routine, would you have had direct patient interaction?
No, typically I don't see the patients. Everything that I would do is just little bits here and there that I get from nursing staff, and so sometimes those pieces are missed just because we don't have that patient interaction.
but this has changed all of that, right?
Yes,
So now you do
yes.
get to go in and see the patient. So how has that made your role in patient care easier?
Well, now that we get the whole picture, it makes everything easier. So some medications are dosed based off of patient's weight and height and things. If a patient has an amputation or a patient like muscular dystrophy, you can see those little pieces on a chart, but they don't make sense. And so now we get to see the patient, and it is just better, effective care. Especially for discharge planning, those things we would not be a part of at all, essentially. So now it's just better patient care and understanding from their side as well.
And it's probably a little bit rewarding to see these patients throughout their stay and to be a part of that care team and to know that you were hands-on in helping them through that recovery. So can you tell us a little bit about that?
Yeah, well, the thing I love working about here is that it is a community. So a lot of these patients, I might not know them, but I know their cousins, their nieces, their uncles. It is very much community based, and so almost everybody is connected in some way to somebody here. And so, yes, to be able to put a familiar face together, make them feel more comfortable with us, and seeing, our patients going home, it is good.
And a big part about getting well and getting healthy is our medications and making sure that all of that is lined out. So whenever, can you tell us a little bit about how it is or how much maybe not easier but more organized you can keep, or, the better communication with the family because you are in the room versus in a room with papers flying at you and we don't know, like you had talked about, you don't have the full picture. So can you tell us the difference that it makes, I guess, in your day-to-day?
From being in the room compared to sitting downstairs?
Yes.
How it makes a difference being here. And just, you said like the organization
Yeah,
and...
just like your day-to-day practices and how your day looks now that you are in the room with patients versus whenever you didn't have any kind of patient interaction.
Yeah, it definitely makes the day a little bit more challenging. I'm still doing the same job. I just have about 10 hours less a week to do it. But having everything together with the patient, we're doing so much more than what we were before. Like I said, those education pieces, home med recs and things like that, we can do only so much by looking at papers and calling facilities. Just because a bottle says that they're supposed to take something twice a day doesn't mean that they're actually doing that. So there's a lot to this job that I could not do behind a desk. And I think if you talk to a lot of people nationally, there are some gaps that are always missing in healthcare. And so this is one way that we're trying to combat that.
Is there anything that you would like to add for people to know about this program, things that you feel like would be beneficial for them to know whenever they're choosing where to receive their care?
Yeah, I know some people, when they see a whole group come into their room, like, oh my gosh, this is a little intimidating. Some patients have mentioned like they don't want the extra people in the room. But anytime you're in a hospital anywhere, these people are looking at your chart and see everything. They just don't see your face. So this care team is here to help, and there's so many more pieces that are included in the healthcare that are not here without the team.
That was perfect.
All right, can I get you to say and spell your first and last name for me?
Dushant Lohano, Dushant Lohano.
Okay.
Okay.
Good to go.
So you are a student. So tell me what you're gathering from this new procedure.
I'm working on a project called Doc AI, and I'm looking at the discharge process here on the acute center, and I'm just shadowing Dr. Lohano.
So how is this procedure helping you better the discharge process?
Yeah, well, I'm getting to understand like what patients are concerned about when they're getting ready to be discharged, and I'm also viewing what the nurse is doing to discharge the patient and what forms they're giving them, so I can understand better about the discharge process, and then I'm going to do a new implantation in it.
What does that new implantation look like?
I'm working on video discharge instructions, which are animated video discharge instructions, and I'm using AI to create those animated videos using the discharge instructions already created by the nurse. So those papers will be uploaded onto a platform where it will be converted with AI to video, which we send to the patient.
Can you tell us how you think that it eases the discharge process as a whole whenever the patient gets to interact with their whole care team?
Wait, sorry, could you repeat that?
So do you think that the discharge process is easier on patients whenever they get to see their whole care team because they get to ask all the questions and have their family ask questions? Do you think that that's an easier process for them?
Well, I think that is definitely an easier process because usually a lot of time patients will not know what they need to do when they go home, and that's one reason why I'm shadowing as well. My videos will make it so that when they do go home, they'll be able to watch videos easily, 1 to 2 minute videos, and understand exactly what they need to be doing, so they don't need to keep calling back so often, keep coming back so often, which reduces the readmission rates.
Is there anything else that you would like people or potential patients to know about your videos or just the process as a whole?
I mean, just watch them with an open mind. Right in the beginning, we're just starting right now, so it's not going to be as like high in depth, but definitely just enjoy them.
And are the videos, they're not fully replacing the doctor interaction, right?
No. Yeah, so so after the doctor visits them, so it's going to be the same process, except when the nurse goes back to their workstation to do the discharge instructions and fill out the paperwork, they'll upload that to the platform, and then the video will be sent to the patient after the nurse verifies that AI did it correctly.
And that video will be able to be shared with all of their family members and anyone that might be helping take care of them?
Whoever the patient lists, when they, first I have to call them and ask them, are you willing to do this? And then it'll be sent via a HIPAA compliant link, so that only the patient and their listed participants can access it.
Perfect. All right, I think we're done.
Thank you.
Wasn't so bad. I would say your role a little bit is helping put patients and their families' minds at ease, that if they've had a hospital experience before where there was a lack of communication or they just didn't feel like they had all the answers that they needed, they went home kind of confused on what exactly had happened or how to move forward. This is helping to eliminate some of that. Of course, it's not a perfect system, but it is helping to kind of narrow down on how many flaws we have when we go home.
Yeah.
Say and spell your first and last name.
First and last name, Michael Graber, Michael Graber.
Good to go.
All right, so tell me from your perspective how this has changed just the patient experience.
I feel like it's changed the patient experience we have everybody in the room. Families feel like we're more involved here since the change. They're not left in the dark so much. We have pharmacy there. We have the doctors that the family can ask questions directly to. We've got case management for planning for when the patient goes home. There's respiratory is there at times, and when we go in and round, it's better for everybody because we can hear the plan straight from the doctor. The family can hear the plan straight from the doctor. They can ask any questions they have right there on the spot, and it makes it really nice.
Do you feel more supported in your role due to this?
Yes, definitely. I've been in places where we didn't round at the bedside, and if doctors are hard to reach or it's a busy moment, it can make it a lot more difficult. So just having everyone there in the room, talking with the family, everyone's involved, it makes things a lot easier from a nursing standpoint for sure.
And what has the patient and family feedback been like?
They enjoy a program like this because of how involved they can be and ask their questions when they have them, and just not being left in the dark, which a lot of places that's sometimes what happens. They're not sure what the next steps are, or if there's going to be help needed in the home, or where the patient might be going for rehab, things like that. It's been a good change here.
And it also allows them the opportunity to see a lot of faces that they normally wouldn't be able to.
Yeah, a lot of times, they don't even see where the care is coming from, who's giving the orders behind the scenes, or what all is happening. So it allows them to put a face to the name.
Is there anything that you would like people to know or that you think is important for families to know when they're choosing a place of care?
I would, if it was my family member, I would want him, you know, to be somewhere where the care is so involved like it is here, and where a program is in place like this. That way I can know the plan, I can rest a little easier about it if it was my own family member. So yeah, I would definitely recommend choosing a place with a program like this where there is rounding at the bedside and the care is so involved.
Perfect.
Yep.
That was your soundings.
So, can I get you to say and spell your first and last name for me?
Paige Schaefer, PAIGESCHAEFER.
Okay.
Good to go?
Good to go.
All right, here we go.
Okay.
So you definitely have a unique perspective, and it's different people have shared stories today on diabetes in particular, and how because of this team rounding effort that you have helped people get off of their medication and learn new lifestyles to help their care. So can you just walk us through some of those instances and success stories?
Okay. I don't know if I have any particular
It
success stories.
It doesn't have to be. Just you know, you are in the room with the patient and all of these other members of their care team, and due to that, you know, what different steps have you been able to take due to all of you being together that maybe you wouldn't have had you not had everyone in the room?
I can better understand what is going on with their medical perspective, so we can determine
Let's start with this one.
Okay,
How do
sorry.
no, you're fine. You're fine. How do you broach the subject with a patient about their diet?
Normally, I just ask them like how their appetite is doing, and if they understand anything about their diet that they're currently on at the hospital, and then go from there to kind of open the subject up about diabetes and how diet can help control that. It is a lot easier whenever the doctor is like there in person and able to kind of tell them about the diagnosis, and then I can follow up with them, kind of clear some like apprehension from the patient. So they are like pretty nervous or understandably upset that like maybe they have like a new diagnosis, but we can kind of ease that. I try to kind of ease that that them being scared basically about what their future is, and kind of let them know exactly how they can help themselves, and kind of reassure them that it's not as hard as what they might think that it is.
I think that maybe this is a personal experience, but talking to a dietitian is usually my least favorite part of having a care team. So do you think that having everyone in the room with you helps to better establish that plan moving forward when it does come to our dietary and lifestyle needs?
Yeah, I think that I can better assist them with questions, because a lot of times whenever the doctor is like first telling them or talking to them about it, they'll talk about like, you know, what they shouldn't do or the rules that they should follow. So I kind of help guide them on what those rules are to make them not as scary to them. But yes, I think that helping them, or it helps me to help them, because I already know what their questions are, or can talk to them about what their apprehensions are that they've already mentioned to the doctor instead of having to have them repeat it. But I can't say that much has changed as far as like whether or not they want to talk to me, even whenever everybody's in the room, but it's definitely easier to answer any questions that they might have, because I don't think a lot of people realize just how much diet affects every aspect of your life. So it's easier to kind of determine what I should talk about as well, what's important to them.
Sure. And then can you just elaborate a little bit on, so diet does affect every aspect of our life. So what are some common misconceptions that you see or that you have seen with this new program, or just in general, that maybe people should be more aware of?
That's a good question.
Is it relating to how different medications maybe affect how our body processes sugars or
Yeah.
our energy levels, and so maybe we don't want to lead as active of a lifestyle due to a medication or something that maybe wouldn't have been thought of had you not been in the room with a pharmacist?
Can you repeat the original
Yeah,
question?
of course.
Sorry.
So you had talked about my question led me. Do you remember? Can you talk to us about some different, like, common misconceptions or things that people should know about how much their diet affects their lifestyle?
Oh, yes. So energy is a huge one. I think that people don't realize that their lack of energy is coming from their lifestyle or their diet, rather than just their disease state or their condition. A lot of times people just attribute it like to their fatigue, to, you know, having complications with diabetes, but in reality, if we tweaked a little something here and there or ate at a different time or something like that, a lot of times people don't realize that, like, those energy pitfalls can have a lot to do with food or their lifestyle. I can't think of any other things off the top of my head, sorry.
You're okay. I know that this is a fairly new process that has been kind of enacted, but has there been, or do you foresee there ever being a time where, you know, you have this big group in the room where, you know, maybe you might catch something that would be beneficial? You know, if you're going to take this medication, you need to make sure that you eat more of this, or you need to make sure that you pay more attention to this.
Yeah. Trying to think of an example, like a specific.
Diabetes would be the easy one to fall back on, right?
Yeah. A lot of times I catch, like, the patient, like, asking diet questions to the physician, and the physician will give them, like, roundabout answers or, like, very generalized answers, and it's easy to know. It's easier now to know when I can come back and talk to them separately about specific, I don't want to say rules or like recommendations that they can help, that will benefit them. Specifically, one of them was not diabetes, but pancreatitis. They were asking more about, like, their diet, if they should do anything, and the doctor was just like, low fat. And I'm like, okay, that's general. So I went back afterwards and kind of explained to them what that means, and explained to them, like, what foods would be good for that, what foods wouldn't be, things like that. But yeah, it's definitely easier to recognize patients that want to know that information, and then also things that I normally wouldn't be consulted on. I'm able to determine, should I go ahead and consult them anyways because they have all these questions. Yeah.
And it probably gives you a lot more opportunity for one-on-one time with that patient, so that patient does feel better supported, but you also feel better supported in your role.
Right. Before we started the rounds, actually, I felt like I recently started my job. So I felt like I didn't know sometimes why I was consulted, so it really helps to know the reason behind it, and also it makes going into the patient's rooms easier afterwards, or just in general, so that way I already developed that, like, rapport by them knowing my face, or even sometimes we get introduced, and then that way they feel patients feel more comfortable with me coming into the room and recognizing that I'm, part of the healthcare team. Because I don't always have something on like that's, I don't really have like a uniform or anything, so people are just kind of like, who is this person? So.
Is there anything else that you would like to add, or that you would like patients or families to know about the program as a whole, or just in your specific dietary? And it's okay if the answer's no.
I don't think so, but
Perfect.
I'm also terrible at thinking whenever I'm nervous.
The only question